Welcome to this workshop on obstetric emergencies. And the SWIFT M mandatory multidisciplinary training program refers to a skill based, woman and baby centered, innovative, focused, transformational, multi professional training. And it has two components. The phase one is the masterclass you are attending today on obstetric emergencies. And the phase one also has a separate component of intrapartum fetal heart rate monitoring through physiological CHG masterclasses. And the phase two is after training the multidisciplinary team, it's about having obstetric fire drills or mock drills on shoulder dystocia, on umbilical cord prolapse, maternal collapse, postpartum haemorrhage, sepsis, etc. So welcome to this short presentation, and we are going to address some of the most important maternal and fetal or neonatal obstetric emergencies during this workshop. So let me start with recognition and management of postpartum hemorrhage. And if you look at maternal deaths worldwide, it shows a tremendous variation. Even among developing countries, Sri Lanka is notable to have the lowest maternal mortality rate, and it is not only due to the good public health system and good obstetricians and midwives, but also is due to very high rates of female literacy. In countries where the female literacy rate is not optimum, there has been an association between that and high maternal mortality rate. And in some countries is very high, 1 in 10 in some countries in Africa. In the UK, the maternal mortality has been varying between 10 to 13. The latest report is about 12. But the sad reality is approximately 300,000 women or mothers die around the world due to pregnancy and childbirth. And that is sadly one woman, one mother dying once in every 2 minutes. And with regard to postpartum hemorrhage, it's about one mother dying every 4 minutes. And that's why we are here to prevent this wide variation in maternal deaths, often due to substandard care. This is the latest report from the UK. September 2025, you can see the top causes of maternal death, and postpartum hemorrhage is also one of the causes of leading direct maternal deaths. And the sad reality is, compared to the period in 2009 to 11, we have increased the maternal death rate by 7%. Although there was an aim to reduce it by 50%. And this is taking away the maternal deaths due to COVID-19 infection. So even if you exclude those deaths, the maternal mortality rate compared to what it was 15 years ago has not gone down, despite of more investment, more technology, and more trainees and more midwives being employed. It is actually getting worse by 7%. And these are the top causes of maternal deaths. You can see thrombosis and thromboembolism, which we'll be discussing later, is a leading direct cause of maternal death, and hemorrhage is also one of the causes of maternal death. And it is really sad that even in a developed country like the UK, the report has concluded that a different care would have given rise to different outcome in 45%. In other words, almost half of the mothers who died need not have died if the care has been different, and only 21% had good care. So let's go back to postpartum hemorrhage. When we were fetuses, or really embryos, we were trying to invade the mother's spiral arterioles so that we could get more oxygen as we grew. So we remodeled the maternal spiral arterioles, we destroyed their tunica media, we made placental venous sinuses, intervillar spaces, so that we could be okay. But it had come with a cost to the mother. Because if you see the velocity of blood flow, that is the blue squares, and if you also see the diameter of the uterine blood vessel compared to the non-pregnant state, if you see what is happening, is almost double. The diameter has doubled and the velocity has increased 4 times by 20 weeks, and that increase continues throughout pregnancy. At term, you're going to have a uterine artery which is approximately 3.5 millimeters in diameter, compared to, you can see, about 1.5 millimeter diameter in a non-pregnant female. And also the velocity of blood flow has increased, and that means that the amount of blood that is going into the uterus is also going to increase. So imagine if a woman approximately has 5 liters of blood, and if she is passing about 1 liter of that blood volume through the uterine arteries every minute, and out of that, half of it goes through the placenta, approximately 500 mLs. Within 5-10 minutes, if we are not careful to manage and stop the bleeding, a woman can become hypotensive and die. And that explains why around the world, about every 4 minutes, a mother dies due to postpartum hemorrhage, because there's a huge increase in the blood flow during pregnancy. And if you look at blood flow at term and compare with the blood volume, you really don't have much time. This I'm talking about in an optimal situation. But let's consider if there is anemia complicating pregnancy, or if there is another coexisting problem like heart disease, where the loss of blood volume will not be tolerated as a healthy young fit woman. So immediately after birth, that is a problem, because the fetus comes out and then the placenta gets separated, and which means there is a huge raw area of maternal venous sinuses, and the blood supply to the placenta, this is exposed, and that is going to really cause an increased risk of bleeding. So we did have protective mechanisms, nature's protective mechanisms. One is the living ligature, so the uterine arteries, uterine muscle fibers, the myometrial muscle fibers run transversely, longitudinally and obliquely, making a system of living ligatures. So the blood vessels are going through these complex muscle fiber arrangements, so that after the delivery of the fetus, as the uterus clamps down, as it contracts, all these blood vessels are squeezed as if we are putting a surgical ligature. There is also contraction and retraction of the myometrium throughout labor. So the myometrial length is also getting shortened at the end of every contraction to push the fetus out. But what it means is it reduces the chance of bleeding after birth with oxytocin. And then there is increase in the coagulation factors, and that again enables the woman to form an immediate clot at the large placental surface to prevent her from bleeding. So nature does provide certain protective mechanisms to prevent maternal deaths due to postpartum hemorrhage. But often if you see confidential inquiries to maternal deaths, it is the concept of too little being done too late that is the one that causes problem. Sometimes we don't do sufficient risk assessment. We don't estimate the accuracy of blood loss. That's too little awareness. Then we have too little responsiveness. Even after we see a lot of blood being lost, we are slow to start IV fluids. We are slow to start drugs that contract the uterus. We are slow to give blood transfusion. And sometimes we are too late to act, which includes inserting a tamponade balloon, decision to perform surgery, etc. So now let's take a moment, discuss with your neighbor as well as with your course facilitator regarding the causes of primary postpartum hemorrhage. So let's take a moment to understand what are the causes of primary postpartum hemorrhage. So we know the concept of 4 T's: the tone of the uterine muscle, the tissue, which is the placenta and the membranes, trauma, which is genital tract trauma or uterine trauma, and thrombin, coagulopathy. It could be acquired, it could be due to loss of blood volume, it could be due to conditions like placental abruption or preeclampsia, where you can get disseminated intravascular coagulation. And 80 to 85% of all atonic postpartum hemorrhage, primary postpartum hemorrhage are due to uterine tone problem. And once the fetus is out, the myometrium has to really contract to stop the bleeding from the placental site. So if this process does not happen, we are going to have a tone problem. So the next question for us: how good are we in predicting the risk factors for postpartum hemorrhage? There have been a lot of studies. I've just given a meta-analysis which looked at this issue of risk assessment. So they did a very systematic review, and they found that in terms of predicting major postpartum hemorrhage, we are not good at risk assessment. We cannot predict it by risk assessing. And if you look at operative births, again, just because the rate of operative births increases, it doesn't mean that the risk of minor postpartum hemorrhage can be predicted. It's just reaching significance. But what we are interested in is major postpartum hemorrhage. Can we predict major postpartum hemorrhage when you do a vacuum or forceps birth? Unfortunately, there is no way of predicting major postpartum hemorrhage. So I was privileged to be part of the Green Top Guideline on Postpartum Hemorrhage published by the Royal College of Obstetricians and Gynecologists, and we wanted to look at certain practical aspects to help frontline clinicians. We wanted to find out what are the risk factors, and if you have a risk factor, which of the 4 T is it affected by, and what is the magnitude of risk, so that we can, as frontline clinicians, we can understand the risk, think of how high is the risk and what is causing it, so we can treat it. So you have a risk factor. This is from the guideline table, which are the 4 T's that is relating to this risk factor, and what is the likelihood of occurrence. So just to give you an example, if you have multiple pregnancy, it's a tone problem. We know that's the 4 T is tone, and it is about 4 to 5 times increased risk of postpartum hemorrhage. Similarly, preeclampsia, if you have postpartum hemorrhage and preeclampsia, often it is due to thrombin, DIC, disseminated intravascular coagulation or coagulopathy, and the risk is quite high, 5 times the risk. Please don't forget episiotomy. We take it so lightly, but it is a trauma problem. That is one of the 4 T's, and that can increase the risk of postpartum hemorrhage almost as the same as multiple pregnancy or preeclampsia. So we need to be really careful on risk assessment. And if we have identified an antenatal risk factor for bleeding, which is serious, I'll give you an example, placenta accreta spectrum. Then we have a time. We have time to predict and anticipate bleeding and take steps. So there's an 8C approach. So first C is care plan with the multidisciplinary team with the patient's consent, explaining what are we proposing to do and why we are doing it. We need to have competent clinicians who are skilled to perform the procedure. We need to have a cell saver. We need to prophylactically catheterize the pelvic blood vessels, the anterior division of the internal arteries with the help of interventional radiology. We had to then have cross-matched blood in the theatre and again have a clotting blood cascade to maintain blood products, etc. We should have measures to control hemorrhage readily available, including tamponade balloons. And we have to also think far that this woman might bleed a lot, and therefore we need to have admission in the neonatal unit. So, intensive care unit. So the immediate management of postpartum hemorrhage is about calling for help. That's the first thing we must do. And then we need to maintain airway, breathing, circulation while we are calling for help. Because we need other people to help us, but airway can kill a patient before breathing, and breathing can kill before circulation. So ABC is very important. Secure the airway and breathing. Make sure you have 2 large bore cannulae to make sure that we give enough volume replacement. And volume itself will not help. So as soon as possible, depending on the amount of bleeding and rate of bleeding, we need to again restore the oxygen carrying capacity of blood, and that is by blood transfusion. And if there are any visible blood vessels, for example, from the perineum, from the vagina, from the cervix, they need to be immediately clamped. Otherwise, there's going to be risk of hypotension. And we should not forget the concept of autotransfusion. Please remember that in humans, approximately 1 liter of blood is present within the calf veins and the lower limbs. Just by raising the calf vein and the lower limbs, or the calves and the lower limbs against gravity, just lifting them up gently, would give approximately 500 to 1000 mL of immediate autotransfusion, so which could help in a very emergency situation. So massive postpartum hemorrhage has been defined in various ways. Some have a number more than 2 liters or 1.5 liters. Some would define it based on the rate of bleeding, so you don't have to wait for the absolute number. If you are in front of the woman and she is bleeding at the rate of more than 150 mL per minute, we know that in 10 minutes she is going to bleed 1.5 liters, and therefore we need to immediately help by arresting the bleeding and making sure that replacement is on the way. Based on the number of blood transfusion, and that is quite late, that is good for audit purposes, and this is a retrospective diagnosis. And we'll be looking at certain concepts today, physiological concepts. A woman losing more than 30% of blood volume. It's very easy to calculate this. Take the booking body weight, and then add 2 zeros. So because it's 100 mL per kilogram, that is the approximate blood volume during pregnancy, 90 to 100. So it's easy to make it 100 and just put 2 zeros to the booking body weight. So if I come to you with a body weight of 65 kilograms, my estimated blood volume is approximately 6.5 liters. or 6,500 milliliters. If I come to you with a low body mass index and my body weight is 4.45 kilograms, my estimated blood volume is going to be 4.5 liters. So based on that, we need to calculate what percentage of blood volume has she lost. So then we have hemodynamic alterations in this situation, and we'll be looking at two specific physiological parameters to recognize ongoing blood loss, and that is going to be rule of 30. We will come to it very soon, and the obstetric shock index. So these parameters would tell us the degree of blood loss. Absolute number 1.5 or 2 liters. The rate of blood loss 150 mL per minute. Have we given 4 units of blood transfusion? That is a retrospective in the postnatal ward. What is the percentage of blood volume that she has lost? So that is by calculating the estimated blood volume and then calculating how much has she lost, the estimated blood loss, to find out whether she has lost 30%. And to have specific tools, rule of 30 and obstetric shock index. And the drop of hemoglobin, again, it is not it's helpful in a prospective situation, but retrospectively for your audits, it generally 500 mL of blood loss equates to 10 grams per liter or 1 gram per deciliter. So if the hemoglobin has fallen from 11 to 8, that is 3 grams. So every 500 milliliters correspond to a gram. So this woman, by losing 3 grams, has lost about 1.5 liters approximately. So that also could help in our audits to see how accurate we are estimating the blood loss as. The next question is, as frontline clinicians, how do we make sure that we estimate the blood loss accurately? Because if we don't estimate the blood loss accurately, we cannot treat postpartum hemorrhage in a timely manner. So if we have either visual estimation, looking at with the naked eye, or we have quantitative estimation, which is either weighing, gravitational, or we measure the actual blood volume lost by using polythene pouches and bags, and that is your volumetric method. So if you look at scientific evidence, we know that visual estimation of blood loss is notoriously inaccurate. The Sarah Patterson Brown's team from London did this study to show if you give obstetricians, midwives, nurses, anesthetists, theatre nurses, scrub nurses, various amounts of blood which is pre-measured and ask them to estimate, none of them got it right. We usually underestimate blood loss. It's not only an obstetrician and midwives problem or nurses problem, but it is also anesthetists and the theatre nurses. They are also not that accurate in estimating the blood loss. And that is the problem. But generally, if the whole bed is soaked, the woman has lost about 1,000 milliliters or 1 liter. But if the bed is soaked and blood is spilling onto the floor, then it is about 1.5 liter as a general principle. But we routinely underestimate blood loss. We try to feel better if it is 1.5 liters to call it 1 liter. So the next question is, if you look at the literature, how accurate are we in estimating the blood loss or even weighing, etc.? Or does it really help if you estimate it correctly? So the current scientific evidence shows that yes, estimation of blood loss correctly is helpful in terms of estimation of blood loss, but it doesn't improve the outcomes, because it is simple. Outcome depends on what we do and how soon we do it. So just because I know that there's a 1.5 liter blood loss has happened and I'm very accurate about it by weighing it or measuring it, if I don't consider the weight of the patient to say, oh, this 1.5 liter for a 45 kg woman is 30%, which is very, very significant compared to the same 1.5 liter accurate estimation to a woman with 60 kgs, which is only about one fourth, 25%. So it's a critical management that changes the outcome, and that's why the American College of Obstetricians and Gynecologists, the ACOG, has released a statement, and that they clearly say that the accurate measurement of blood loss does not improve maternal outcomes. It's what we do that improves maternal outcomes. So definitely weighing and measuring is much better than looking a visual estimation in terms of how accurately we estimate it. But that itself doesn't improve the outcome. So when I was a labor ward lead consultant in a teaching hospital in London, we used to get expired blood from the blood bank because it's expired, and we used to spill in the labor wards, and all of us, including me as a labor ward lead consultant, we had to go and estimate it ourselves, because we have to constantly train ourselves on how to estimate a blood loss. And I used to give Kit Kats to those who get it right, because it has to be a constant process of spilling blood and then estimating it, so that when it really happens, we know how accurately to estimate it. So early estimation of blood loss is important. We use something called Obstetric Shock Index, which is very, very easy. A pulse rate divided by systolic blood pressure. So if you check my pulse now, it's about 70. My systolic blood pressure is about 110, and therefore the ratio is going to be less than 1. It's about 0.1 to 0.7. And in adult medicine, it was shown that if it goes, the shock index goes to more than 0.9, there's a significant blood loss. But in pregnancy, we know that the systolic blood pressure falls in early pregnancy. The pulse increases by about 10 beats, and therefore we cannot use normal adult parameters in pregnant women. So that's why obstetric shock index is very important. What we showed about 10 years ago by studying women who are pregnant and who have lost blood is that the obstetric shock index, or OSI, which is pulse divided by blood pressure, during pregnancy is not 0.5 to 0.7, but it is 0.7 to 0.9. But it is very easy. If it crosses 1, in other words, in an emergency, just ask for the pulse rate and the systolic blood pressure. If the pulse rate has crossed the systolic blood pressure, it is more than the systolic blood pressure, then the woman has had at least 30% blood loss volume. So this is the paper we did, and we showed that if the obstetric shock index was more than 1, then there's a 30% chance of 30% loss of blood volume and 70% required blood transfusion. So in an emergency, in postpartum hemorrhage, all we need to do is to check the pulse, check the blood pressure and systolic blood pressure. If the pulse has gone above systolic blood pressure, approximately she has lost 30% of the blood volume. So this study was again repeated by Andy Shannon's group in a larger population, and again they showed that the shock index, the obstetric shock index, is very, very important parameter during pregnancy. So in a massive postpartum hemorrhage, in addition to visual estimation of blood loss, in addition to weighing or volume estimation, please check the pulse and the systolic blood pressure and calculate the obstetric shock index. So that's the first tool that will help us to accurately estimate blood loss. The second tool is rule of 30. So if the woman has lost more than 30% of blood volume, her pulse rate is going to increase over more than 30 beats per minute. The respiratory rate is going to go about 30 per minute. The systolic blood pressure drops by more than 30 millimeters of mercury, and the urine output drops to less than 30 mL per minute. She becomes oliguric. And finally, if you check the blood, the hematocrit or packed cell volume drops by 30%. So everything is 30. So if you find these parameters, irrespective of what others are telling you about the estimated blood loss, please think that this woman may have lost more than 30% of the blood volume for these parameters to be clubbed together. So again, in the green top guideline, we mentioned about obstetric shock index as well. And often the degree of shock is compared to tennis. How we score tennis. If you look at tennis, scoring is 15, 30, 40 dues, and you win or lose. So if your pregnant woman loses 15% of the blood loss volume, that's about 1,000 liters in terms of estimated or actual blood loss. What happens? Her respiratory rate increases slightly, the pulse, blood pressure, everything remains normal, and she becomes a bit anxious. But if she loses the next 15 to 30% of blood volume, that's about 1.5 liters. That the respiratory rates goes above 30, and the pulse increases now, tachycardic. But remember, the systolic blood pressure remains normal, but the diastolic blood pressure increases. That's because of intense peripheral vasoconstriction due to catecholamines. The diastolic blood pressure reflects the peripheral resistance, and because of that, the diastolic blood pressure increases. So please look at the rise in the diastolic blood pressure as she starts bleeding. And this is the reason why the pulse pressure, which is the difference between the systolic and diastolic blood pressure, narrows. So if your systolic blood pressure is 120 and the normal diastolic blood pressure was 80, the pulse pressure is 40, 120 minus 80. But when the woman loses 15 to 30% of blood volume, due to intense vasoconstriction and rise in the blood pressure, diastolic blood pressure to say 90, 95, the pulse pressure gets narrowed. From 40, it becomes about 15, 20. It is only when the woman loses more than 30% of blood volume, that's about 2 liters. Again, please think of these numbers in the general population, and these numbers are derived from Caucasian population, not in Asian or Chinese population where the body mass index is less. And this is the reason why in the UK, sadly, the maternal death rates among Asian and African population is high, because we have been using the same standards. No, if an Asian woman or Chinese woman weighs 45 kilograms, she only has 4.5 liters, not 6.5 liters. And therefore, we cannot wait for 2 liters as a cutoff. That's too much. That's almost 40% of the blood volume. And then they have a cardiac arrest. So this is the time they reduce the systolic blood pressure. So if you are worried about, if you are concentrating on systolic blood pressure, we will lose that patient because it changes only very late. And finally, if it goes beyond that, that is actually imminent death. Until that time, there's anxiety and confusion and agitation due to sympathetic response. And then it becomes a comatose situation due to lactic acidosis, etc. And that is imminent death. So let's make sure that we don't allow women to go through this the spectrum. We recognize and treat postpartum hemorrhage as soon as possible, so the outcomes are much, much better. And the shock index, which is pulse rate divided by systolic blood pressure, as you can see, at this point itself, we would have picked this woman up if we have used obstetric shock index. Because the systolic blood pressure is still normal, but the pulse has increased, it crosses the systolic blood pressure, so we will be able to pick these women up. So this is a sad case quite recently. This woman was bleeding, and the midwives were giving, and the doctors were giving biscuits, ginger biscuits, thinking that she was feeling faint. And that's because we have been using set thresholds in all women. Please don't use one number. We are all different. My blood volume is different to your blood volume, and therefore you cannot expect me to bleed the same as you would just because some guideline tells you to do that. So please use let's individualize care. In addition to your vital parameters, please use your obstetric shock index. Please use your rule of 30 and calculate what is the estimated blood volume for this patient, and then find out what is the estimated blood loss, and find out whether she has lost 30% based on her own estimated blood volume. It's not someone else's blood volume. So the principles of management are very simple. We need to prevent postpartum hemorrhage. We need to make sure that postpartum hemorrhage is prevented by early risk assessment, early recognition of ongoing bleeding, so that it doesn't become postpartum hemorrhage, and a multidisciplinary approach. That's prevention. But once it happens, we need to do two things. We need to think of medical treatment, and we need to think of surgical treatment. So let's do medical and surgical treatment next, to find out how do we help these women. Then finally, we need to avoid severe maternal morbidity and mortality, because women who bleed, have massive postpartum hemorrhage, they are going to be vasoconstricted, they are going to have multi-organ failure or risk of multi-organ failure. The gut is going to be ischemic, so if you feed her too early, she is going to have paralytic ileus. So we need to be careful. If a woman has lost 1.5 liters, remember she is in a very strong vasoconstricted state, and all the organs are at risk of reduced oxygenation at the expense of central organs, and we should be very, very careful managing her. So let's now take a pause after recognizing that once a woman bleeds 2.5 liters or 1.5 liters, the red stuff we see, they are red cells and the hemoglobin within the red cells. But that is not the only substance or the vascular parameter she is losing. She is also losing fibrinogen and clotting factors. What we see is red, but there's plasma too. And because of that, we had to be very careful of a condition called washout phenomenon. So if the woman has lost more than 1.5 liters, not only she has lost red cells that requires blood transfusion, but she has also lost fibrinogen and platelets from the plasma. And this is the reason, if massive blood loss is encountered, we need to think of coagulopathy and correct the coagulopathy as well. So let's take a pause to understand the 4 T's. So have a discussion with your neighbor and also with the course facilitator. Go through what are the risk factors, the 4 T's, the tissues, the thrombin, the trauma, and the most important, tone, and then think of all the possible definitions of massive postpartum hemorrhage. Discuss among yourself about obstetric shock index by giving each other different vital signs to calculate. Try to calculate the estimated blood volume and the ratio of the estimated blood loss to blood volume by giving different body weights and different blood volume loss, and then put everything together and think of what is the prevention of postpartum hemorrhage, how I'm going to prevent postpartum hemorrhage, how I'm going to diagnose and act on postpartum hemorrhage, and what are the possible complications. Then we will do our part 2 going forward.